Hi there. This is Dr. Josie. I'll go live for a little bit to address some questions that I had this week, and I thought I'll bundle them. I thought I will bundle them in a live session. This week has been busy, so I'm a little slower, and my voice is a little hiccupy, but we'll see how far we come. I got a lot of questions this week related to breast cancer, in particular anti-estrogen therapy, and in particular aromatase inhibitors. I got some questions about people who couldn't tolerate them and what to do when they can't, and some people who are about to start an aromatase inhibitor and are not sure what to expect. So that topic is huge, and I can sit and talk here for the next few days if I wanted to, but I'll try and pick out some helpful comments, and let's see if there's any questions that come during the live or after the live, and we'll see where we can go from there. Aromatase inhibitors are the newer kid in the block. They there's 3 currently FDA approved. There's Arimidex, Aromacin, and Famera. At this point, they're being used in any order. They're approved to be utilized in any order. Most of the time we start with Arimidex because that's sort of the oldest one that has been around, but they all came out around the same time. At this point, they're all reasonably affordable. Sometimes one may not necessarily be as affordable as the others, depending on what your health insurance is covering. What I'm trying to say is that the biggest driving factor in choosing which aromatase inhibitor to use is often its tolerability. Aromatase inhibitors are used, anti-estrogen therapy is used, both in the metastatic setting as well as in the non-metastatic setting, to try to, in the metastatic setting, to treat hormone-responsive breast cancer, in the non-metastatic setting to try to reduce the recurrence risk. And so also there, in both situations, deciding on the benefit versus the risk, the pro and the con, balancing these two differs in both settings. And how it differs depends on the person. Some would argue that the stakes are higher in the metastatic setting. Some would argue the stakes of anti-estrogen therapy are higher in the non-metastatic setting. And so it really depends on the individual. But to focus today on tolerability, all 3 aromatase inhibitors, in theory, have the same side effect profile and have the same protective effect in terms of preventing/treating hormone-responsive breast cancer. Side effects usually can start to appear within 1 to 2 weeks of intake, and side effects between the 3 aromatase inhibitors are in theory the same, but sometimes if you go from one to the other, the severity of the side effects may change, or another symptom might become more dominant, more problematic than it was on another aromatase inhibitor you may have tried. Let me back up for a second. Aromatase inhibitors work by blocking your estrogen production. And if you understand that, you will understand the side effects of an aromatase inhibitor. Aromatase inhibitors are only approved for those who are postmenopausal, either naturally or medically or surgically induced by ovary removal. And the reason for that is that aromatase inhibitors block the peripheral production of estrogen, meaning even if your ovaries don't make estrogen anymore, you still make estrogen in your peripheral, in particular fat tissue. And that production gets disrupted by the use of an aromatase inhibitor. And so in theory, through the feedback loops, if your ovaries are still working and they sense this peripheral blockage, your brain may signal to your ovaries, you got to work a little harder. And so in theory, if you're premenopausal, your ovaries can compensate, if not overcompensate, for peripheral blockage, which is not what we want. And so he would argue, why would we ever then put a premenopausal woman on an aromatase inhibitor? Well, the reason for that is that sometimes somebody is deemed to be postmenopausal because of chemotherapy and other treatments they've been through. It looks like they're postmenopausal because their menstrual period has been absent for a year and their blood work may be consistent. But the younger you are, the higher the chances are that your ovaries may resume function. And so it's important that you communicate clearly with your doctor, and your doctor hopefully asks you every time if you're still at risk for having your periods return, that you tell them, I think maybe I start to sense some hormonal cycle changes, or maybe most obviously, I think I start to have vaginal spotting again. When that happens, don't panic. Just call your cancer doctor, the one who prescribes the anti-estrogen therapy, and let them know. Most commonly, what they will do is put your treatment on hold for a little bit and just give you a script to check your blood work, just to see where your ovaries are at. But going back to why you started talking about this, good morning, Kathy. Good morning, Lisa. Is aromatase inhibitors block the peripheral estrogen production. And so they can have symptoms that are very similar to menopause. Hot flushes, night sweats, vaginal dryness, moodiness, risk for bone loss. I think a symptom that's very unique to individuals who are on an aromatase inhibitor are the arthralgias, meaning aches and pains in your joints that are likely related to sudden changes in your estrogen levels. And those in a third of the women, and those numbers are likely underestimates, can be so bothersome that you will have to call us, your cancer doctor, to discuss what to do for them. These aches and pains in your joints are usually the worst in the first 4 weeks or so. And so some cancer doctors will tell you, why don't we try to push through the first month and see how you do after that. Usually these aches and pains respond well to over-the-counter pain medications, in particular anti-inflammatory like NSAIDs. Good morning, Ingeborg. Good morning, Sharon. Because there's some inflammatory component to these aches and pains. But if a regular over-the-counter dosing of something like Motrin, Aleve, Advil does not do the trick, then I would talk with your cancer doctor. I would talk with them anyway before you start your Motrin, Aleve, and Advil to see if they are okay with you using that. So that may help many of you over the hump of the first month. But there is, like I said, about a third of individuals who have such severe aches and pains or discomfort on the anti-estrogen therapy that those individuals need to stop the current aromatase inhibitor that they're on. Oh, thank you, Sharon. I'm sending a big hug to your daughter, Jennifer, too. I remember her very well. I have fond memories of her. She was very kind to me, and that's I think, a very, very good feature to have, kindness. Thank you, Sharon. You raised her well. Now, the tricky part is that there is really no clear evidence on what to do when somebody doesn't tolerate an aromatase inhibitor. There's guidelines out there that are based on consensus, and as a result, every doctor will do things slightly differently. And so take what I tell you as an empowerment to feel comfortable to talk with your doctor, but I would follow whatever your own doctor tells you to do. But in general, if somebody calls in with, totally being miserable, uncomfortable, then I would tell them to stop the current aromatase inhibitor. I usually give an individual a few weeks break, 2 to 4 weeks, but many of my colleagues don't. They switch from one day to the other to another, the next one of the other 2 remaining aromatase inhibitors. I usually give somebody a little bit of a break to allow them to recover, and then I start them on one of the other 2 residual aromatase inhibitors. Somebody asked me if the chance of intolerability goes up or down by trying the next one. And in my experience, it can do either. But once you have demonstrated an intolerability or difficulty tolerating one aromatase inhibitor, your risk of having difficulty with another one is not uncommon. And so what I usually do for that reason, before we start the second attempt with or switch to another aromatase inhibitor, is I would try to talk and sit down and reflect with the cancer survivor on what's happening, to see if there's anything in their body, in their system, that we can improve on. Are they not sleeping well? Are they anxious or depressed? Are they having some nutritional deficits? Are they exercising, moving less than they did? Just to help them get their body better in sync in whatever way it might be, through a comprehensive evaluation. And after we've put things back in sync, then I usually have a better idea, a better expectation, I should say, on them tolerating a next try with an aromatase inhibitor better. I almost feel like if you start them on a second aromatase inhibitor without making changes in between, that's almost sort of doomed to fail, because the likelihood of them not tolerating a next try is very, very high. I also tell individuals often to go into it neutrally. Don't expect the best, don't expect the worst. Just see how you do. If somebody is at high risk of getting aches and pains from an aromatase inhibitor, despite everything that I just said, on top of that, I would sometimes start somebody already on Motrin dosing, Aleve, Advil, when they try the second attempt with an aromatase inhibitor to help them through that first month of worse aches and pains. But again, don't start this on your own. Discuss this with your own medical doctors and go from there. I usually try this for a little while. What I forgot to say is those individuals who get terrible aches and pains, I would also do some lab work, make sure their thyroid is intact, make sure their organ functions are intact, some of the vitamin levels are intact, like D and B12. And I would assess them for autoimmunity, just to make sure we're not dealing with some autoimmune disease like rheumatoid arthritis, very low risk, but it's also very easy to check and rule out. So if an individual is not able to tolerate a second attempt either, then, like I mentioned, we have a third aromatase inhibitor. Sometimes I would try that one. If they fail all three, some individuals say, I'm done. Some individuals say, I would like to go back to the first one because in hindsight I tolerated it the best. Some individuals are willing to try tamoxifen, which was the golden standard for postmenopausal women until the aromatase inhibitors came out. They work, aromatase inhibitors work a few percentage better than tamoxifen, but something is better than nothing. And we have older agents than tamoxifen too that we can use. And in some individuals, we keep trying. Like I said, we go down the list of agents. We try them for a few months. They come back. They don't tolerate it. We try another one. And then after we've been yo-yoing like this for 2 to 3 months, 2 to 3 years, I usually start to wonder, what are we doing here? And usually the survivor will ask the same thing. And at that point, we may have to have a very thorough discussion about the pros and the cons and the benefits and the risks. Yo-yoing your hormonal system up and down every time is probably not in your own benefit either. Experiencing stress related to you not tolerating it and trying it again is often putting a very high pressure on a cancer survivor. And so in the non-metastatic setting, to prevent cancer from recurring, to reduce the cancer recurrence risk, I often have a discussion at that point with the survivor to decide on, is the benefit really worth the risk? Individuals used to have to take it for 5 years. Now in the non-metastatic setting, it's 10 years. And so there's many options that we can explore in terms of medication, tweaking in terms of duration that they're on. And we know that any duration is helpful. So even if you can't finish the 5 years, it still will give you benefit that outlasts how long you were on the medication. What I mean with that is we know that anti-estrogen therapy taken for 5 years still has benefit 15 and now 20 years out, meaning your medication will continue to protect you beyond when you're taking it. Lastly, I would like to tell you that 2 years ago now, maybe, in a very high-ranked journal, I think, what is that journal called? The JNCCN published an article on examining breaks that individuals take between anti-estrogen therapy agents when they need to so-called recover. And that particular article found that if breaks were taken for medical reasons, like it just outlined, to try and allow you to recover, not because you feel on your own like you wanted to stop the medication, then it did not have a negative impact on your outcome. And so I guess my message is, hopefully this information empowers you to speak freely and honestly without shame or guilt with your cancer doctor. Because there's many things your cancer doctor can do to try to help you tolerate your anti-estrogen therapy. You don't have to be ashamed that you're bothering that person, that you've failed. I want you to be honest. If you tell us honestly what's going on, then we can help you. I hope this helps you. Shay is telling me that she's had 8 years of Arimidex. Thank you. 8 years is a long time, Shay. Yes, I know. It's good to see you here. It's good to see all of you here. Are there any questions that any of you have for today? If not, you can always post them later here, and then you'll give me some inspiration to go live in a few days again. I hope all of you are okay. In Pittsburgh, it's raining, which makes me feel home in the Netherlands. I love rain, which brings me to a new book that came out. It's called Bittersweet. I'll post that today or tomorrow. It's about individuals who embrace the good and the bad. That sometimes melancholic state is not necessarily a bad thing. You can't see the sun if you haven't had some rain. But I love rain. At 11 o'clock today, we will go live with Brad. Brad will be leading the session. He is a retired English professor from the University of California in Sacramento, and he will do a session to help us write, to allow us to heal. That's one way of healing. There's many different ways of doing that, but writing is one of them. And so we hope that some of you will join us. And I hope to see you soon again. Thank you, Sharon. Thank you. I'm so happy to hear from you. I miss all of you. Will you say hello to all your colleagues there and give them a hug on my behalf? Thank you. Thank you, everybody. I wish you a good day. Thank you. Bye.